Okay, good afternoon, everyone. It's my great pleasure to speak here. And thanks for the introduction from the host. And I'm a radiologist from Peking University First Hospital, and my major is gastrointestinal imaging. So today I'd like to share the application of MR angiography in small bowel disease. So before we start, maybe someone of you will ask me the question, why conducting MR angiography? I think most of you must have heard of MRI. MRI means a magnetic resonance imaging, and it is a very useful tool with great value in many fields, especially in medicine. And in last centuries, some scientists won the Nobel Prize in MR field, and such as the famous one, Paul Lutberg. And MR angiography is just a very small part of the MRI and just focus on the imaging of small bowel. And speaking of the imaging modality of small bowel, we have to mention CT angiography. Compared to the MR angiography, CT angiography has the advantage of faster imaging, better spatial resolution, cheaper price, and comparable diagnostic efficacy. So since we already have CT angiography, why we still conduct MR angiography? First, MR angiography has no radiation danger, but CT angiography does. Second, MR angiography has a higher resolution of soft tissue contrast, which could help differentiate the lesion's characteristics. And third, beyond the morphological imaging, MR angiography has many sequences to choose, and some of them are functional sequences. And these functional sequences could provide some functional information of the lesions, and indirectly reveal the pathologic changes inside. And the last one, MR angiography could provide the real-time imaging of the small bowel, so that maybe MR angiography could be used in the evaluation of the movement. So these are the normal appearance of the small bowel on MR angiography. Because of the fluid fields in the lumen inside for the preparation, and the fluid inside the lumen will show very bright on both Fiasta and T2-weight images, and we call this high signal intensity. And the bowel wall surround shows very thin and homogeneous dark color, which was called low signal intensity. And on T1-weight imaging, the fluid will show low signal intensity. After introduction of the contrast agents, the bowel wall will show homogeneous and moderately enhanced. So this is outline, and I have three parts to introduce. The first one is MR features of common neoplasm. Before we take a look at the images and make the final diagnosis, the most important thing you needed to do is get to know the patient's history and the current examination results. Why? Because many bowel diseases have overlapped images, so that under most conditions, it's impossible to make the correct diagnosis if we don't know the patient's history. For example, for the young people, malignancy is rare, but IBD is common. What is IBD? IBD means the inflammatory bowel disease. But for the old people, malignancy is common while the IBD is rare. So it is important to get the patient's history before we take a look at the images. When we take a look at the images, we usually use the following steps. The first one, we need to check if there is any abnormality or not. Second, if we are sure there is any abnormality, we need to analyze what kind of distribution of these abnormalities. Are they just focused or segmental or continuously or skipped? And then we need to look at carefully what kind of signal intensity changes on different MR sequences. For example, and we need to check the enhancement styles. For example, Stratification enhancement is one of the enhancement of the bowel disease. Stratification enhancement just only seen in inflammatory disease, but rare in malignancy. And finally, we need to check if there is any abnormality in other organs. And it is also could helpful for our diagnosis. For example, if there is any abnormality in peritoneum, it always suggests two kinds of disease, adenocarcinoma and tuberculosis. So this is a common types of neoplasm of small bowel, and it could be divided into two groups, the benign types and the malignant types. Adenoma, lymphoma, stromal tumor belongs to the benign ones. Adenocarcinoma and lymphoma belongs to the malignant ones. So we'll check them one by one. First, for the adenoma. Adenoma is the most common type of the benign tumor in small bowel, and it usually appears as a nodule with or without stalk, or just within the mucosa. After introduction of the contrast agents, it always appeared as marked homogeneously enhanced. So let's see an example. This is the adenoma. We could see this nodule is here. And always, most of the benign tumor in small bowel always appears the same, just like a nodule with homogeneous enhancement and well-defined and smooth margins. Okay, this is enhancement, shows homogeneous enhancement. Lipoma. And I think it is the easiest to give the diagnosis of lipoma because lipoma has a very special and very typical image feature. For MR sequences, we have a technique called fat saturation. So what is fat saturation? We could say these are two pictures. These two pictures are the same sequence, just T2 with the imaging, and for the same patient. But one is bright and another one is dark white because this one we use fat saturation. So if the sequence without fat saturation, all the fat tissue and the lesions containing fat tissue will show apparently high signal intensity. But if we use the fat saturation, all the fat tissue and lesions containing fat tissue will be low in signal intensity, such as the lipoma here. So the lipoma will appear with high signal intensity on sequences without fat saturation, but will decrease in the sequence with fat saturation. So it's easy to make the diagnosis. Stromal tumor. It is also called the borderline tumor because it could be either benign one or the malignant one, and it always depends on the pathological results. The typical features for the stromal tumor is its location, because almost all the other tumors in small bowel were located either in the mucosa or in intramural, but only the stromal tumor could be located extramural. So that is the typical features for stromal tumor. So this is an example for the stromal tumor. And we could see the tumor is here, and this is a benign one. Also, we could see the well-defined and the smooth margins here, and it located extramural. And still, stromal has another important images, and it have a very good movement. You can see the movement from here to here. Of course, it moves with a small bowel. And we also could see the movie here. You can see the movie, and we could see tumors here. And as we mentioned before, stromal tumor could be a malignant one, and when it turns malignant, and the shape will turn irregular and obscure borderline here. Adenocarcinoma. Adenocarcinoma is the most common type of malignant ones in small bowel, and adenocarcinoma usually takes place in older people, and usually it involves in this a very short segment of the bar, just less than 5 centimeters. That's the difference from the inflammatory disease. And the bar wall will show circumferential and or irregular thickened here. And this is another adenocarcinoma. Also, could say they involved a very short segment of the bar, and the bar wall shows circumferential and irregular thickened, and the lumen shows stricture. Okay, last one, lymphoma. For the lymphoma, it has various types of imaging appearance. It could appear as either the adenocarcinoma or the inflammatory disease. But the important thing for lymphoma is that it's very soft. Because even if the tumor grows very big, but it rarely induces the obstruction of the bar. But the inflammatory disease and the adenocarcinoma will do. Okay, let's move to the next part, MR feature of lung neoplasm. In fact, there are various types of nonneoplasm in small bowel, but today we just focus on the Crohn. Crohn is one type of IBD. So what is IBD? IBD means inflammatory bowel disease. How we remember it? I, inflammatory mesentery. B, bowel wall changes. D, disease complications. So from its name, we could image what will it be like. It will involve both the mesentery, the bowel wall, and with the possible complications. So this picture depicts almost all the possible changes for the IBD, especially for Crohn. So first, for the inflammatory mesentery changes, including the fat changes here, engorged vessels, and the swelling of the lymph nodes. And for the bowel wall changes, it may have the permanent structural changes, thickening of the bowel wall and stratification of the bowel wall, and with ulcer or granuloma. For the complication, it may include the perforation, fistular abscesses, and also it could say maybe could be the cancer, stricture of the lumen, and the dilation of the proximal bowel. So let's see an example. This is MR angiography. It could depict all the pathologic changes here. So first, we could say a relatively longer segment bowel wall was involved. That's the difference from the carcinoma. And we could see the bowel changes, bowel wall thickened, and the stratification enhancement for the bowel wall, and the stricture of the lumen. And also we could see the engorged of the vessels in the mesentery. And we could, from the different MR sequences, we could see different pathological changes for Crohn, such as for the T1 weekly imaging after contrast injection, we could see the stratification of the enhancement. So what is the stratification enhancement? We could from this picture, we could see the enhancement of both mucosa and serosa. And between them, this is submucosal, but the submucosa did not enhance. So this is stratification enhancement. It is very common in acute inflammatory disease, but is rarely seen in malignancy. And for the T2 weekly imaging, if we use the fat saturation, we could see the fat tissue inside the submucosal here, and it always suggests a chronic inflammatory disease. And if we find the edema of the bowel wall on T2 weekly imaging, it always suggests the acute stage. Okay, let's move to the last part, the advanced development of MR angiography. As I mentioned before, there are many sequences could be chosen for MR angiography, and some of them could provide some functional information, such as diffusion weekly imaging, abbreviated as DWI, magnetic transfer imaging, abbreviated as MT, And this is the popular one, radiomics, artificial intelligence, such as deep learning, machine learning, and so on. And also the movie imaging. So what is DWI? WI scale. And this is the different sequences used in one patient, and we could find the lesions scale. This is FIASTA T2 with imaging, and this is T1 with imaging with after injection of the contrast agents. You can see in this scale, this is DWI. Compared with the other three sequences, DWI maybe could not provide more clear morphology, but the highlight signal intensity in the lesion could suggest this lesion was at acute phase. And for the magnetic transfer imaging, it is still at the research stage. And from the studies, we could say magnetic transfer imaging could extract the fibrosis in the bowel wall. Because the fibrosis, if there is any fibrosis or not, is very crucial for the therapeutic strategy. And also, again, for the movie, we've already seen it before. We could say how the bowel movement, and if there are any narrowing or stricture. And there is another movie. We could see the lesion is here. And we could see the lumen is relatively narrowing here. And this is one post-surgery. Surgery is here. And we could also, from the movie, we could see the narrow of the lumen here. So again, from the radiomics is a software could extract the textural features from the images, maybe provide more information for the fibrosis, and it's still at the research stage. And in future, we need to first improve the spatial resolution of MRI and reducing scanning time, because MRI angiography will cost about 30 minutes. 30 minutes is relatively long. Maybe nowadays some techniques will help us, such as the compressed sensor techniques. And we need more functional sequences, maybe you could give us more functional information, such as APT, ATKI, and so on. And since MRI angiography has no radiation danger, maybe it could be used in the healthy screening or in children. Okay, thank you.
Thank you for your presentation. This was quite interesting. I don't know if there are any questions from the audience.
Yeah, maybe actually I'm very interested in this Professor Liu's talk. It's interesting not only because I'm working on imaging field, but this is very amazing that I can see the MRE can provide such high quality image of the small bowel. It's the bowel wall and all the like tumor boundaries can see the feature of the boundaries, like smooth boundary or speculate boundary. We can see that nicely. So for the MRE, mostly you use single, let's say single static images to do the analysis, or you usually sometimes will take movies, right? Because bowel is moving. You also showed the movies to us.
Okay, this is a very good question. Before the examination, we will use some drugs to the patients, and will reduce the movement for the power for the bar. And we usually for the FIASTA, this kind of questions balance how to spell it? This kind of sequence is not very sensitive to the bar movement. So we do this, so we usually use this kind of sequence to give the bar imaging.
I see. So for the imaging quality, as you mentioned, the resolution can be a further improvement aspect. And probably also analysis with these images. We one side we will do imaging. We will get images from the signal and form images. That's how we get high quality, like high resolution, high contrast. And the other side, once we have these images, we need to analyze these images and extract information to serve the diagnostic purpose. So from your clinician or doctor point of view, there must be some like technical guys, people approach you. So you think the development side for, let's say, for AI, now it's a hot topic, how that can help you to improve the clinical experience.
Okay, that's a very amazing question. That's what I wanted to do. Yes, and yes, we have a relatively long time for the scanning, and sometimes the patients can't be still in the scanner, and some image quality will be reduced, and we can't always get the best image quality, and because it depends on the preparation for the patients. First, the patients should be prepared very well, drink a lot of about 2,000 milliliter water, then, and for the technique, and we want to use some advanced techniques such as the compressed sensor. This kind of techniques could actually accelerate the scanning time without influencing imaging quality. And maybe next time we want to use that. About the AI, you mentioned that, and I have communicated with the scientists, but they have no idea about this so far, because the bars move, so it's very difficult for them to focus. So so far, they need to maybe, if we want to do this, we first they told me they need to set a model, and then we should analyze. There's no available software now to analyze directly.
It's not easy task. Yeah. Not
yes.
easy task. Right. Okay, it's very nice answer, explanation. Thank you very much. Also, thank you for accept our invitation to give the talk. Thank you.
Thank you. Thank you.
Thank you for introducing us to such innovations. That's wonderful.